Good evening, everyone. Today I'm going to uh, present the topic of rare case of calcinosis universalis under the supervision of Dr. Urmila ma'am. The patient is a 15-year-old female. 4 years back, she presented with periorbital edema, photosensitivity, intermittent fever, and painful bilateral lower limb weakness. For that, she received steroids from a local hospital. Later, in few months, she developed painless nodules on arms, erythematous rashes on face, and was started on a total 60 mg OD and methotrexate 7.5 mg per week from a government hospital. So she was having reduced symptoms of rashes and weakness, and her methotrexate dose was increased to 15 mg per week, and steroid was tapered off in 1.5 months, and she was doing fine. Later, after a few months, she lapsed, and she again was started on 2 mg per kg steroids, and she left the treatment after 1 year. During the treatment, during the time she was lost to follow, she developed nodules in low limbs, progressive low limb weakness, and became non-ambulatory. And she developed an ulcer under the left knee. After now for 6 months, she presented with hyperpigmentation on face and progressive low limb weakness. And she was taken in, and her general physician examination showed pallor, non-scarring alopecia, patch on soft palate, diffuse hyperpigmentation on nodules, and nodules on face, bilateral arms and legs, Gorton sign on knuckles, bilateral pedal edema, calcinotic ulcer under left knee, and CDASI score was activity score was 1, and damage score was 16. So this was hyperpigmentation and painless nodules on arms, and this was the calcinotic ulcer under the left knee. Her skeletal examinations, MMT8 could not be performed because she had contractures in knees and elbows, and she could not turn into prone position. There was maximum weakness in neck flexors and shoulders, which was 2, and the CMAS was 3, single breath count was 40, and joint contractures in bilateral knees and elbows, and systemic examination was normal. Her life findings showed us anemia, which was 8.7, and CPK and LDH was raised. CPK was 897, LDH was 1400, and ferritin was also raised 196. Her autoimmune profile showed ANA 4 plus nucleophile speckled, and an MSA profile showed 3 plus MI2A and 2B positivity. And radiology showed calcinosis in elbows and bilateral thighs, in bilateral hip region. In shoulders were normal, and her chest X-ray was also normal. And her hand X-ray showed diffuse osteopenia with joint space narrowing. So final diagnosis was juvenile dermatomyositis, MI2A and 2B, calcinosis universalis, which was also related, and anemia of chronic disease. Treatment, we gave her non-pharmacological management, high protein diet, and range of motion exercises. Non-pharmacological management, which was given, was 1 mg per kg steroids, 25 mg omnacoti, JAK inhibitor, tofacitinib syrup, 4 mg, and pamidronate 1 mg per kg IV for 3 consecutive days every 3 months. After 3 months, her steroid dose was reduced to 15 mg. Hyperpigmentation was reduced. There was no worsening or reduction in calcinosis, probably because she was not taking it, not compliant to the treatment. Discussion: anti-MI2 antibodies are present in 4 to 10% of patients with JDM, and it's usually associated with anti-NXP2 or TIF1 gamma. Calcinosis is reported in 20 to 47% patients, and type 1 interferon signature is elevated. So unusual aspects of this case was MI2 associated calcinosis universalis, because there are only case reports and case series of MI2 associated calcinosis, and calcinosis occurring within few months of disease onset, because JDM and juvenile dermatomyositis calcinosis can be due to can indicate activity rather than chronic disease in adult dermatomyositis. So calcinosis in JDM can be due to local trauma, active inflammation, and distribution of proteins and calcium metabolism. These all play parts in calcinosis formation. And excessive calcium storage and release to STAT3 pathway has been hypothesized. So tofacitinib can be used because it blocks the STAT3 pathway. And JDM patients should be referred timely to rheumatologists to prevent contractures and calcinosis. This was an article which included 80 JDM patients, and tofacitinib was used, and 50% had complete clinical response, and 75% patients had reduction in size and number of calcinosis, and 15% had complete resolution of calcinosis. Thank you.